Hello again. So yes, as Nigel said, I'm going to briefly summarise what we found from the anaesthetic part of the activity survey. So in this part of the project, data were collected from every single case that was under anaesthetic care at each hospital site over a pre-specified 2-day period. When I say anaesthetic managed care, that included all cases where sedation was delivered or the patient was just monitored, as long as it was by an anaesthetist. It also included obstetric cases, including epidurals for labour, and all different types of regional anaesthesia. It didn't include routine sedation in the intensive care. Data was then scaled up to provide an annual caseload, and was also, as Nigel said, used to provide denominator data for how frequently certain drugs were used and to give a picture of what type of patients we're anaesthetising and how we're anaesthetising them. We could also use this data to compare what was happening in our practice with the data that was collected from the NAP6 activity survey in 2013 to try to identify any differences that had occurred in those 3 years. Given the recent interest in the weekend effect, we also sought to look at, in more detail, the working patterns of anaesthetists and look at anaesthetic-specific work, how it was spread across the different days of the week. So we identified 356 hospitals from the Royal College database of NHS sites, and of those, 342 sites participated in this part of the project. 11 of those sites said that they didn't have any cases that were eligible to contribute to this part of the data. Therefore, over 16,000 case report forms were returned from 336 hospitals. Of these case report forms, a small proportion, around 250, were uninterpretable, giving us a final number of 15,942 cases that were included in the final analysis. Using that number, we devised a scaling factor that converted it from 2 days to a week, and then from 1 week to a year, taking into account bank holidays. And we also incorporated the number of sites that responded and also the estimated response rate at each site into the scaling factor. This gave an estimated annual caseload of just over 3.1 million cases. And of those, nearly 59% were female patients. This chart just shows the spread of cases divided up by the speciality of the main procedure. Again, unsurprisingly, orthopedics and trauma featured most frequently, followed by general surgery, gynecology, urology, and obstetrics. We wanted to look at the body mass index of the patients that we were anaesthetising, and although the majority of patients were of a normal BMI, over 20% were obese or morbidly obese. And actually, there was a statistically significant increase from NAP5 in the proportion of patients that were morbidly obese. This graph just shows the breakdown of obesity by age category, showing that the majority of morbidly obese and obese patients were adult patients. These two charts illustrate how frequently we are operating on different days of the week, and it is broken down by NC-POD classification of urgency. So on the line chart, you can see that this dark line represents elective workload, and that the majority of elective cases are done during the working week from Monday to Friday, with Monday and Thursday being the busiest elective days. And elective operating does decrease over the weekends, but actually on Saturday and to a less extent on Sunday, we are still performing elective procedures. This chart also shows that more urgent surgery is happening pretty consistently across all days of the week. This bar chart shows the proportion of cases that were under the direct care of a senior anaesthetist. When I say a senior anaesthetist, this includes consultants and specialist grade doctors. And sorry for the confusion, but the yellow bars here are the elective cases. And this shows that a very high proportion of elective cases are directly supervised by a senior anaesthetist, regardless of the days of the week. More urgent procedures, again, under the direct care of a senior anaesthetist, a very high proportion of the time, particularly during the week, but this does slightly drop off at weekends when a lower proportion are supervised by senior anaesthetists. These are similar charts, but this time they're broken down by ASA grade, representing how unwell the patient was. And again, it shows that the majority of ASA 1 and 2 work happens during the working week, probably as a result of the elective caseload, and that this decreases over the weekend. The most severely unwell, the ASA 4 and ASA 5 patients, this seems to be more consistent across the working week, although numbers were much smaller. And ASA 3 grade patients seem to sit a little in the middle, but are relatively consistent across the days of the week. Again, this bar chart represents what proportion of patients were under the direct care of a senior anaesthetist, and we can see that a very high proportion of all cases are under the direct care of a senior anaesthetist, especially the ASA 3 and 4 cases, as well as the ASA 1 and 2 cases. But at the weekend, again, this does slightly decrease. I, to some extent, ignore the ASA 5 cases because they were so infrequent, and this might be a bit anomalous. The specialty whose workloads most commonly occurred at the weekends was obstetrics, with nearly a third of their cases occurring at the weekend. This was followed by orthopedics and trauma and general surgery. If you're an anaesthetist working at the weekend, which specialties do you most frequently encounter? Well, orthopedics and trauma is the most frequent part of your workload at weekends, followed by obstetrics and general surgery. Obstetrics did stand out as a specialty with the lowest number of cases under the direct care of a consultant anaesthetist or specialist grade doctor. And this was particularly prominent at weekends when just around 40% of cases were under the direct care of a senior anaesthetist. When we look at the more urgent cases, category 1 and category 2 caesarean sections, a very high proportion of these are being led by registrars, and especially in comparison to category 4 caesarean sections, when a very high proportion are led by consultants. We also looked at where induction of anaesthesia was occurring. So of all the general anaesthetic cases, induction occurred in an anaesthetic room in around 77% of cases, and around 19% induction occurred in theatre. This is very similar to the picture that we saw in NAP5 and doesn't appear to be changing. And the specialties where induction occurred in theatre most frequently included obstetrics, thoracic, and dental surgery. This did to some extent vary with the urgency of procedure as well. We looked at how frequently depth of anaesthesia monitoring was being used. We noted that in 12% of general anaesthetic cases, depth of anaesthesia monitoring was used. And this was more frequent when total intravenous anaesthesia was used compared to volatile anaesthesia, and was used more commonly when a neuromuscular blocking agent was used. Cardiac surgery was the specialty that showed the highest use of depth of anaesthesia monitoring, and this had changed a great deal since NAP5. So in NAP5, only 2.8% of general anaesthetic cases involved the use of depth of anaesthesia monitoring, and we're now up to 12%. We also looked at the use of neuromuscular monitoring. In 37% of cases where general anaesthesia was used in combination with a neuromuscular blocking agent, a peripheral nerve stimulator was used to monitor neuromuscular blockade, and in around 3% of the time, quantitative monitoring was used. Peripheral nerve stimulators were more commonly used with rocuronium and atracurium than other types of neuromuscular blocking agents. And this actually had not changed really at all since NAP5. So in NAP5, the figure is 38% use peripheral nerve stimulators in general anaesthetic cases with neuromuscular blockade. So this doesn't appear to have changed in the intervening 3 years. So in conclusion, there appears to be an increase in elective weekend working and weekend working in general when we compare it to other studies on this subject. There is a high proportion of direct senior involvement in our urgent cases and in cases involving the sickest patients, but this does decrease slightly at weekends. There has been quite an increase in the use of depth of anaesthesia monitoring since NAP5, potentially as a result of recommendations made in that, but this does not seem to have impacted the use of neuromuscular monitoring, which has stayed very similar in the intervening 3 years.
Thank you very much. So improvement in depth of anaesthesia monitoring, but sadly, one of my own subjects, not neuromuscular blocking agent effect monitoring. Very disappointing. Interesting to reflect on why that may happen. Now, the next presenter is Susanna Marino from Manchester, and she'll be presenting the last of the survey data for NAP6. This is particularly important because we need to talk about incidences, we need to talk about risk per 100,000 exposures, we need denominator data to tell us how many exposures there are. It's very important to try and get this accurate, and we think we manage that reasonably well. Just counting up the number of ampoules of X, Y, and Z sold doesn't really help us a great deal because we don't know how many ampoules are thrown away, particularly with succinylcholine, how many drugs are drawn up and never used, again, succinylcholine. In particular, the important thing is actual usage, and so that is what we measured, actual exposures, and Susanna's going to tell us about that. Thank you.